Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite.
Hey, it's Howie Mandel, and I am inviting you to witness history as me and my Howie Do It gaming team take on Gilly the King and Wallow 267's $1 million gaming in an epic global gaming league video game showdown. 4 rounds, multiple games, 1 winner, plus a halftime performance by multi-platinum artist Travie McCoy. Watch all the action and see who wins and advances to the championship match against Neo right now at globalgamingleague.com. That's globalgamingleague.com. Everybody games.
Hey everyone, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. Today's episode is part 2 of our discussion of arthrology, the study of joints, also known as articulations, as requested by listener Mykenzie from Minnesota. This is an important topic in A&P, especially for anyone looking into clinical practice. Joints are where much of the movement of our skeleton takes place, and when you have movable parts, you have the risk of things going wrong, like injuries. Shoulders, hip, knee, ankles. These are going to be a big percentage of emergency room visits, and if you're interested in orthopedics, physical therapy, massage therapy, chiropractic, etc., this is enormously pertinent. If you didn't listen to part 1 of my discussion on joints, I recommend going back and doing that first, because in that episode I covered the definition of joints, the major classes, the concept of lever systems, which explains the mechanics of joints, and the subtypes of the major classes of joints. Today we'll focus on the most clinically significant joints, synovial joints. I'll cover the angular movements that take place at synovial joints and the structure and function of principal joints of the human body. Maybe I'll even get into a little clinical information on some of those more commonly injured joints. But before we can talk about knees and wrists and what they do, we need to start with the language of joint movements, because this vocabulary is foundational for anatomy and physiology, kinesiology, physical therapy, and clinical practice. Joint motion is described relative to anatomical position, the standard 0 position. From that reference point, we name deviations from anatomical position and returns to anatomical position. So let's not waste any more time and jump right into the angular movements that take place at our most mobile joints. We'll start with flexion. Flexion is a movement that decreases the angle at a joint, usually in the sagittal plane. Bending the elbow, bending the knee, curling the fingers like you're making a fist, or bringing the thigh upward in front of the trunk are all examples of flexion. Extension generally reverses flexion and returns the joint back to anatomical position. Straightening the elbow after lifting a cup, straightening the knee after sitting, or returning the arm to the side after bringing it forward. Those are examples. Now, you've probably heard of hyperextension, and that means to take extension beyond anatomical position. Looking upward by extending the neck beyond neutral, or swinging the thigh backward while you're walking are examples. Some joints tolerate normal hyperextension, while others don't, like the elbow or the knee. In the elbow or knee, hyperextension is often associated with injury or abnormal laxity. Abduction, with a B, is movement away from the body's midline in the frontal plane. Raising the arm out to the side or moving the legs apart are examples. Adduction, a deduction, is movement back toward the midline. Some joints can also be hyperadducted, like you can swing one leg across in front of the other. That would be hyperadduction. Elevation and depression are vertical movements in the frontal plane. Examples are shrugging your shoulders or closing your mouth after it's been open. Those would be elevation. Depression would be relaxing your shoulders back down or opening your mouth after it's been closed. Protraction is anterior movement in the transverse plane, while retraction is posterior movement. So, for example, pulling your shoulders back like you're puffing out your chest, that is retraction. But then doing the opposite and trying to draw your shoulders close together like you're trying to hug yourself, that is protraction. The mandible can also protract and retract, like if you stuck your chin out like you were showing an underbite. That is protraction, and then pulling it back is retraction. Circumduction is a movement in which one end of an appendage remains relatively stable while the distal end traces a circle. Imagine stirring a large invisible circle in the air with your arm, or tracing a circle on a wall with one fingertip while the shoulder remains relatively fixed. The motion is not a separate primitive action, and it's not rotation. It's a combined sequence of flexion, abduction, extension, and adduction. So together we call that circumduction. Think of circle. While as rotation is movement around a longitudinal axis. The humerus rotates medially and laterally at the shoulder. The femur rotates at the hip. These rotations are critical in many activities, from changing direction while walking, to swinging a racket, stepping into a car, or pivoting when you're dancing. We talked about supination and pronation earlier. This is most commonly referred to in the forearm. In supination, the palm faces anteriorly or upward, and the radius and ulna lie parallel. In pronation, the palm faces posteriorly or downward, and the radius crosses over the ulna. You supinate to hold a bowl, receive coins, or carry a plate from below. You pronate to type on a keyboard, place your hands on a tabletop, or perform a push-up. These motions depend on the radio-ulnar joints and their associated syndesmosis. The head and trunk have additional specialized movement terms. Flexion of the spine means bending forward, as when leaning over a sink or tying your shoes. Extension returns the trunk upright, and hyperextension bends it backwards. Lateral flexion means bending the neck or trunk to one side. You can have left lateral flexion or right lateral flexion. And right and left rotation refer to turning the trunk to either side like you're twisting. You can also do this with your neck, like you're shaking your head no. These motions are crucial in daily life, such as checking traffic while driving, reaching into the back seat of the car, turning while carrying groceries. At the waist, so-called rotation is a functional composite motion involving multiple structures rather than a single, simple synovial movement. The mandible has its own functional vocabulary because chewing is more complex than merely opening and closing the mouth. Depression opens the mouth and elevation closes it, like I said before. Protraction brings the lower jaw forward, helping the incisors align for biting. Retraction returns it backward. During chewing, the mandible also undergoes lateral excursion and medial excursion. That's moving the mandible side to side and then back toward the midline. This side-to-side grinding is essential for processing food between the premolars and the molars. If the jaw could only hinge vertically, chewing would be much less efficient. The hand and digits also require special terminology. The wrist flexes and extends, but it also moves side to side. Ulnar flexion, more commonly called ulnar deviation, tilts the hand toward the pinky side or ulnar side. Radial flexion or radial deviation tilts toward the thumb side. That's the radial side. These motions appear in everything from painting to hammering to using a computer mouse. The fingers flex, extend, abduct, and adduct in familiar ways. Curling the fingers around a pen is flexion. Straightening them is extension. Spreading them apart like jazz hands, that's abduction, and bringing them together is adduction. The thumb, however, is special because its orientation differs from that of the other digits. During development, it rotates so that its plane of movement differs significantly from that of the fingers. Because of that rotation, thumb terminology can feel counterintuitive at first. Flexion of the thumb bends it across the palm, while extension straightens it. Radial abduction moves the thumb away from the hand within the plane of the palm. Palmar abduction moves it away from the plane of the palm, as when you prepare to grasp a jar lid or wrap your hand around a handle. Adduction returns the thumb toward the hand. And then, like I mentioned earlier, most distinctive of all is opposition, the movement that brings the thumb toward the fingertips. Returning the thumb from opposition is called reposition. Opposition is one of the great triumphs of primate anatomy, enabling precision grip, tool use, and many of the fine motor skills central to human culture. The foot has its own specialized movements as well. Dorsiflexion raises the toes toward the tibia. You perform dorsiflexion when clearing the ground during the swing phase of walking or when you're balancing on your heels. Plantar flexion points the toes downward like you're pressing on the pedal of a car, pushing off during walking, or standing on your toes. Plantar flexion can be extremely powerful and is central to jumping, sprinting, and climbing stairs. Inversion tilts the sole of your foot medially, while eversion tilts it laterally. These movements are especially useful on uneven terrain where the foot has to adapt to rocks, slopes, and irregular surfaces. They're also involved in many ankle injuries. A common ankle sprain often results from excessive inversion. Pronation and supination also apply to the feet, though in that context they describe combined motions rather than simple analogs of forearm rotation like we saw before. Pronation of the foot combines dorsiflexion, eversion, and abduction. Supination combines plantar flexion, inversion, and adduction. These patterns are functionally important in gait or walking. Pronation helps the foot adapt to the ground and absorb shock. Supination helps create a more rigid lever for push-off. Although students often first encounter these terms in the forearm, understanding their meaning in the foot is equally valuable for biomechanics, sports medicine, and rehabilitation sciences. Okay, now that you have an understanding of what joints are, the classes, the general anatomy, the functional mechanisms, the range of motion, and the angular movements they're capable of, we're going to take a tour through the clinically significant synovial joints of the human body. We'll move from the head and neck down to the feet. Our focus is not just on naming these joints, but on understanding how their structure determines their function, why particular soft tissues are so important to their stability, and why certain injuries occur so commonly in some joints and only rarely in others. In anatomy and physiology, joints are where structure and function become especially easy to appreciate. A joint may look small and simple in a diagram, but once we consider the geometry of its articular surfaces, the arrangement of its ligaments, the pull of the surrounding muscles, and the mechanical stresses placed on it during daily life, it becomes clear why some joints are built primarily for mobility, while others sacrifice motion to preserve stability. Recall from episode 84 that all synovial joints share a basic organizational plan. Their articulating bones are separated by a joint cavity, their articular surfaces are covered by hyaline cartilage, and the entire joint is enclosed by an articular capsule that has an outer fibrous layer and an inner synovial membrane. That synovial membrane produces synovial fluid, lubricating the joint and helping to nourish the avascular articular cartilage. Many synovial joints also include accessory structures such as a fibrocartilaginous disc, a labrum, bursae, fat pads, menisci, and intracapsular or extracapsular ligaments. Yet despite this common blueprint, synovial joints vary enormously in shape and in range of motion. This diversity reflects the functional demands of the body region in which that joint is found. We're going to begin all the way at the top, at the atlanto-occipital joint. This is the articulation between the occipital condyles of the skull and the superior articular facets of the atlas, or C1 vertebra. Structurally, this is a synovial condylar joint, sometimes also described functionally as an ellipsoid joint. Because the occipital condyles are convex and the superior facets of the atlas are concave. And this means the joint allows the skull to rock on the atlas. The primary movements here are flexion and extension, the motion of nodding yes with your head. And there's a small degree of lateral flexion. Rotation is very limited at the atlanto-occipital joint because that movement is delegated mainly to the atlanto-axial complex, just below it. Although this joint is not commonly injured in ordinary daily activity, it is highly significant in trauma because high energy forces can disrupt the ligamentous stability between the skull and upper cervical spine. Severe injuries at this region can be catastrophic because of the close proximity to the brainstem, upper spinal cord, and vertebral arteries. In less dramatic settings, dysfunction here can contribute to neck pain, cervicogenic headaches, or restricted nodding and upper cervical mobility. Next is the atlanto-axial joint, really a set of three synovial joints between the atlas and the axis. That's C1 and C2. There is one median atlanto-axial joint between the dens of C2 and the anterior arch of C1. And there are two lateral atlanto-axial joints between the inferior articular facets of the atlas and the superior articular facets of the axis. The median component is a pivot synovial joint, while the lateral components are plain synovial joints. Together, they produce the major rotational movement of the head, the action of shaking the head no. About half of the cervical spine's rotation happens at the atlanto-axial joint. Remember that the axis, C2, has an upward projection called the dens, or odontoid process. It kind of looks like a thumb is sticking up, like the axis is given a thumbs up. And that dens sits inside the anterior arch of C1. And then a ligament goes across, holding it tight, but allowing it to rotate. So we'll talk about some of those softer tissues in that region. And they include that transverse ligament of the atlas, which holds the dens in the anterior arch of C1, the alar ligaments, which limit excessive rotation and side bending, and the tectorial membrane, which is a superior continuation of the posterior longitudinal ligament, the PLL. These structures are essential because the dens project superiorly into the ring of the atlas, just anterior to the most superior aspect of your spinal cord. Any instability here threatens neural structures. And those instabilities could occur from trauma, inflammatory disease like rheumatoid arthritis, congenital ligamentous laxity, or conditions such as Down syndrome. A fracture of the dens is also clinically important, especially in older adults after falls, because rotation is concentrated here. Painful restriction of head turning is a common presentation when the joint or its associated soft tissues are irritated. While we're in the atlas and axis, I want to talk about a couple of fractures that are clinically significant that can take place here. One is called a Jefferson fracture, also known as a burst fracture. This is common when someone dives into shallow water and they hit the top of their head or their forehead, and it forces the occipital condyles into the lateral masses of the atlas. And that could cause the lateral masses to split, creating a burst-like appearance where the axis splits into two from the lateral masses. High risk for spinal cord injury in there. The other one is an odontoid or dens fracture called a hangman's fracture, where the dens actually breaks And then you lose the stability moving anterior and posterior, allowing the atlas to slide forward, allowing the dens to go backward into the spinal cord, another high risk for spinal injury. So those two fractures, Jefferson fracture and Hangman's fracture, are typically fractures that can take place in that upper cervical region and be high risk for spinal cord injury. The reason why the odontoid fracture is called a Hangman's fracture is because it typically is caused by a mechanism of excessive extension and rotation simultaneously, which is what happens from a noose when someone is hanged. Okay, let's move inferiorly and come to the facet joints of the spine, also called zygapophyseal joints. These are synovial planar joints, or plane joints, formed between the superior and inferior articular processes of adjacent vertebrae. Although all are structurally planar or gliding joints, their orientation varies by region, and that region orientation strongly influences spinal movement. In the cervical spine, the facets are oriented to permit substantial flexion, extension, lateral flexion, and rotation. In the thoracic region, the facets and the rib cage limit mobility, especially extension, while allowing some rotation. In the lumbar spine, the facets are oriented mainly to favor flexion and extension while resisting excessive rotation. Clinically significant soft tissues associated with the facet joints include the adjacent intervertebral discs, even though the discs themselves are cartilaginous symphysis joints rather than synovial joints. Facet joints are a common source of spinal pain, particularly with degenerative arthritis, capsular irritation, or mechanical overload. In the cervical spine, facet-mediated pain can contribute to neck stiffness and headache. In the lumbar spine, facet arthropathy commonly causes low back pain that gets worse with extension and rotation. You've probably heard of a whiplash, like a car accident, a acceleration-deceleration injury. In that case, facet capsules could be strained. Because the facets guide motion and bear load, degeneration here frequently coexists with disc degeneration and can contribute to foraminal narrowing and nerve root irritation. Remember that each vertebra, almost every vertebra, has a superior vertebral arch and an inferior vertebral arch. And those two arches come together from adjacent vertebrae and form a foramen, or a hole, and the spinal nerves come out of there. When the discs degenerate, when the facet joints degenerate, the vertebrae get closer together because the disc shrinks. And when the vertebrae get closer together, that foramen gets smaller, what we call stenosis. That foraminal stenosis could start to impinge on the spinal nerves exiting the vertebral column. And that could result in pain, numbness, tingling, weakness, basically symptoms associated with anything that is innervated by nerves that can be traced back to that spinal nerve. The sternoclavicular joint is the articulation between the medial end of the clavicle and the manubrium of the sternum, with some contribution from the first costal cartilage of the first rib. It is structurally a synovial saddle joint, although functionally it behaves in some ways like a ball and socket because of the range of motion permitted by its articular disc and capsule. It allows elevation and depression of the clavicle, shrugging your shoulders and putting them back down, protraction and retraction, and axial rotation. This may sound like a modest list, but it is enormously important because the sternoclavicular joint is the only true synovial articulation connecting the upper limb and the axial skeleton. This is why the clavicle is the most often fractured bone in the body. Its clinically significant soft tissues include a fibrocartilaginous articular disc, which improves congruence and absorbs shock, the anterior and posterior sternoclavicular ligaments, the interclavicular ligament, and the costoclavicular ligament, which is a major stabilizer. This joint is surprisingly strong. Dislocations are uncommon compared with other shoulder girdle injuries, but when they do occur, Posterior sternoclavicular dislocation is especially concerning because the clavicle can compress the structures in the superior mediastinum, including major blood vessels, the trachea, or the esophagus. Sprains and degenerative changes can also produce localized pain, especially in athletes or after trauma to the shoulder girdle. When we move lateral to the sternoclavicular joint, we get out to the shoulder girdle, specifically the acromioclavicular joint first. This is a synovial plane joint between the lateral end of the clavicle and the acromion of the scapula. It allows gliding and subtle rotational adjustment that are essential for full scapular motion during elevation of the upper limb. Without these small but necessary adjustments at the acromioclavicular or AC joint, normal overhead motion would be compromised. The joint's soft tissues are of major clinical importance. This is an area where injury is extremely common. When the ligaments holding the acromion and the clavicle together tear, you get what's called a shoulder separation. In a typical mechanism, such as a fall onto the point of the shoulder, the acromioclavicular ligament may sprain or tear, and more severe injuries disrupt the coracoclavicular ligament as well. The resulting prominence of the distal clavicle creates a familiar step-off deformity. The clavicle rises up because the muscles superior to the clavicle are stronger than the ones inferior. With a third-degree tear of those ligaments, you end up with what's called a piano key appearance. You can actually tap on the clavicle like it's the key to a piano. The ball and socket of the shoulder joint is called the glenohumeral joint. It is formed by the head of the humerus articulating with the glenoid cavity of the scapula. This joint has an extraordinary range of motion: flexion, extension, abduction, adduction, medial and lateral rotation, and circumduction. Its mobility is possible because the humeral head is large, even though the glenoid cavity is relatively shallow. But that same mismatch comes at a price. We get enormous mobility, but poor stability, especially when we compare this to the other ball and socket joint, the femoroacetabular joint of the hip. This is why the associated soft tissues are clinically important. The glenoid labrum deepens the socket modestly. There is a fibrocartilaginous rim around the glenoid cavity called the labrum, and that makes it a little bit deeper. The articular capsule is relatively loose, especially inferiorly, so that we can allow this wide range of motion. The glenohumeral ligaments and coracohumeral ligaments reinforce the capsule, but dynamic stability depends heavily on the rotator cuff muscles: supraspinatus, infraspinatus, teres minor, and subscapularis, or the sits muscle, SITS. The tendon of the long head of the biceps brachii, the subacromial bursa, and the coracoacromial arch are also central to shoulder mechanics and pathology. Those rotator cuff muscles have tendons that cross the glenohumeral joint and attach at either the greater tubercle of the humerus or the lesser tubercle of the humerus. The muscles anchor themselves on the scapula. Those tendons are important stabilizers of the glenohumeral joint, and they also allow for motion, like internal and external rotation and some abduction. Because the glenohumeral joint's mobility and its relative instability, it is frequently injured. Anterior dislocation is by far the most common, often occurring when the arm is abducted and externally rotated. This could damage the labrum, producing what's called a Bankart lesion, or indent the humeral head, producing a Hill-Sachs lesion. Rotator cuff tendinopathy and tears are extremely common, especially involving the supraspinatus tendon. That's the muscle that goes over the top of the glenohumeral joint. I actually had a torn supraspinatus tendon. I had it repaired in February of 2024. It was a long recovery, a good 6-7 months before I could really do anything with it. and a good 12 months before I really was 100%. Impingement syndromes, bursitis, adhesive capsulitis, and osteoarthritis also occur at the shoulder. It is a perfect example of a joint in which the soft tissues matter just as much as the bones. The elbow is often described as a hinge joint, but functionally it is part of a more complex articulation that includes the humero-ulnar and humeroradial joints, all enclosed in one capsule with the proximal radio-ulnar joint. The primary synovial classification for the elbow proper, especially the humero-ulnar component, is hinge. It permits flexion and extension, that's it. These movements are highly stable because the trochlear notch of the ulna grips the trochlea of the humerus pretty securely. The clinically significant soft tissues include the ulnar collateral ligament medially, the radial collateral ligament laterally, and the annular ligament, which stabilizes the radial head. The common flexor and extensor tendon origins are also major clinical landmarks because repetitive strain injuries occur there. Common injuries include elbow dislocation, which usually follows a fall on an outstretched hand, ulnar collateral ligament injury in throwing athletes, and the tendinopathies known as lateral epicondylitis and medial epicondylitis, also known as tennis elbow and golfer's elbow, respectively. The ulnar collateral injury in throwing athletes is what we see common in pitchers in baseball, and sometimes it can be corrected surgically by replacing that ulnar collateral ligament in what's called Tommy John surgery. The proximal radio-ulnar joint lies immediately adjacent to the elbow and is a synovial pivot joint. Here, the head of the radius rotates within a ring formed by the radial notch of the ulna and the annular ligament wrapping around the neck of the radius. Its movement is pronation and supination, though functionally these actions occur in coordination with the distal radio-ulnar joint. Pronation and supination allow the hand to rotate from palm up to palm down positions, a capability crucial for fine motor activity and tool use. The annular ligament is the most important associated soft tissue holding the radial head against the ulna while allowing rotation. The wrist joint, or radiocarpal joint, is a synovial condylar joint formed primarily by the distal radius and the scaphoid lunate and triquetrum. It permits flexion, extension, abduction, which at the wrist is often called radial deviation, adduction or ulnar deviation, and circumduction. Sometimes supination and pronation looks like it's happening at the wrist, like the wrist is rotating, but that's not really happening at the wrist. That's happening at the proximal radio-ulnar joint. Common injuries of the wrist include distal radius fractures, scaphoid fractures, scapholunate ligament injuries, and overuse syndromes. Although carpal tunnel syndrome is technically a neuropathy involving compression of the median nerve rather than a joint injury, it is closely related to the anatomy of the wrist region and is one of the most clinically significant conditions of the wrist and hand. A lot of times people just call it carpal tunnel, but the carpal tunnel is actually an anatomical structure. In the wrist, you have the 8 carpal bones, and they form a little divot the way that they articulate with one another. And in that groove, there are 9 tendons from multiple forearm flexor muscles, and running right down the middle is the median nerve, which innervates the skin and muscles of the lateral half of the hand. That's the thumb, thenar muscles, second digit, and the lateral half of the third digit. Remember, in anatomical position, the thumb is out laterally. And there is a broad ligament covering those, holding them in that groove, creating a tunnel. That broad ligament is called the flexor retinaculum, and that tunnel is called the carpal tunnel. Carpal tunnel syndrome is when one or more of those tendons gets tendinitis, inflames, and makes it so there's less room for everything else. And that starts impinging on the median nerve. So you get neurological symptoms like numbness, tingling, pain, and weakness in the hand. And that brings us to the joints of the hand, which have several categories, each with distinct function. The intercarpal and midcarpal joints are synovial plane joints that allow gliding and contribute to the overall flexibility of the wrist and hand. These are the joints between the carpal bones themselves. The carpometacarpal joints of digits 2 through 5 are mostly plane joints with limited gliding, whereas the first carpometacarpal joint of the thumb is a synovial saddle joint between the trapezium and the first metacarpal. This thumb joint is one of the most functionally important joints in the entire body because it permits flexion, extension, abduction, adduction, circumduction, and opposition. Opposition gives the human hand much of its precision grip capability, allowing the thumb to cross the palm and touch your pinky. The metacarpophalangeal joints are synovial condylar joints between the metacarpal bones of the palm and the proximal phalanges of your digits. They permit flexion, extension, abduction, adduction, and circumduction. Then you have the interphalangeal joints. These are synovial hinge joints allowing flexion and extension between the phalanges. Now the thumb only has 2 phalanges, so there's one interphalangeal joint, and we just call it the interphalangeal joint or IP joint. The proximal phalanges of digits 2 through 5 articulate with the middle phalanges, forming the proximal interphalangeal joint, or PIP, PIP. And then the middle phalanges articulate with the distal phalanges, forming the distal interphalangeal joints, or DIP, dip joints. So we have dips and pips. And the same thing goes for the digits of your feet. Common injuries in the hand are numerous because the hand is constantly exposed to force and repetitive use. At the thumb carpometacarpal joint, osteoarthritis is common because of the repeated loading involved in pinch and grasp. Ulnar collateral ligament injury of the thumb's metacarpophalangeal joint, often called gamekeeper's thumb or skier's thumb, is another classic lesion. Finger collateral ligament sprains, volar plate injuries, mallet finger from terminal extensor tendon disruption, Boutonniere's deformity from central slip injury, trigger finger from stenosing tenosynovitis, and dislocations of the proximal interphalangeal joint are all clinically significant. The hand beautifully illustrates how synovial joints and tendon systems work together to produce both strength and dexterity. Heading all the way down to the bottom of your spine, we have the lumbosacral joint, usually referring to the articulation between L5 and S1. This region includes the intervertebral disc anteriorly and the paired facet joints posteriorly. But the posterior zygapophyseal articulations are synovial plane joints and are particularly important in guiding movement. The lumbosacral angle creates substantial shear stress at this level, so the joint must resist translation moving forward while still allowing flexion and extension. Rotation here is pretty limited, mostly because of the orientation of the facet joints. Clinically significant soft tissues here are the lumbosacral disc, iliolumbar ligaments, facet capsules, and the longitudinal ligaments. But really, we're talking about disc herniations here. L5-S1 disc herniations are extremely common and could compress the nerve roots coming out. We also have a risk for spondylolysis and spondylolisthesis. Spondylolysis is when there is a fracture in the vertebra, where spondylolisthesis is where the vertebra slides forward on the vertebra that's beneath it. The sacroiliac joint is an unusual articulation between the sacrum and the ilium. Much of it is a synovial plane joint anteriorly, while posteriorly there are strong ligamentous connections. There's not a lot of motion in the SI joints. Mainly all you're getting is slight gliding and rotational movements, often described as nutation and counter-nutation. Although the range is minimal, the sacroiliac joint is essential for transferring weight from the axial skeleton to the lower limbs and for absorbing stresses during walking, lifting, and childbirth. Then we get to the femoroacetabular joint, which we often call the hip joint. It is a synovial ball and socket joint between the head of the femur and the acetabulum of the hip bone. It permits flexion, extension, abduction, adduction, medial and lateral rotation, and circumduction. Compared with the shoulder, the hip sacrifices mobility in exchange for stability, the opposite of the shoulder. The acetabulum is deeper, and the bony congruence, where the bones actually meet each other, is far better. Associated soft tissues are therefore tasked with deepening the socket and powerfully resisting dislocation. There's a labrum here, just like we have with the glenoid labrum, there's an acetabular labrum. It deepens the acetabulum a bit. The joint capsule is strong, and the iliofemoral, pubofemoral, and ischiofemoral ligaments spiral around the joint to tighten during extension, helping support upright posture with minimal muscular effort. The ligament of the head of the femur is less important mechanically in adults, but does carry a small artery in some individuals, more significant in childhood. The ligamentum teres femoris attaches the head of the femur at the fovea capitis to the internal socket of the acetabulum. It's an intracapsular ligament, meaning it's inside the joint capsule. Common injuries and disorders of the hip include osteoarthritis, labral tears, femoroacetabular impingement, and fractures of the femoral neck, especially in older adults with osteoporosis. You don't get a lot of dislocation in the hip because there's so much stability. You need a lot of trauma to dislocate the hip. The most complex joint in the entire body is the knee. It's really two major articulations within one functional joint complex: the tibiofemoral joints and the patellofemoral joint. Now, there are two tibiofemoral joints, a lateral and a medial. The femoral condyles, lateral and medial, meet the tibial condyles, lateral and medial. So you have two joints working together to form really one functional joint. It's often described as a hinge joint because it primarily allows flexion and extension, but there is a small degree of rotation possible, especially when the knee is already flexed. Now, the joint between your kneecap, or patella, and the anterior femur is called the patellofemoral joint and is a synovial plane-type articulation in which the patella glides over the femur, improving the mechanical advantage of the quadriceps tendon. Now, the patella is a sesamoid bone. A sesamoid bone means a bone that formed inside a tendon. The tendon that attaches the quadriceps group to the tibia is split into two separate soft tissue structures. A quadricep tendon that goes from the quadriceps muscles, which include the rectus femoris, the vastus lateralis, the vastus medialis, and the vastus intermedius. 4 muscles, quadriceps, 4-headed. That tendon goes from those muscles to the patella. But then there is another soft tissue structure going from the patella to the tibial tuberosity of the tibia, and that is called the patellar ligament. Clinically, you often hear people call this the patellar tendon, but it is not a tendon. It attaches a bone, the patella, to another bone, the tibia. By definition, that is a ligament. So it's the patellar ligament. Now, you also have important ligaments holding the femur and the tibia together. 2 extracapsular ligaments and 2 intracapsular ligaments. Inside the joint, you have the intracapsular ligaments, also known as the cruciate ligaments. The anterior cruciate, which attaches from the posterior femur to the anterior tibia, and the posterior cruciate ligament from the anterior femur to the posterior tibia. You have collateral ligaments on the outsides. These are extracapsular ligaments. You've got a medial collateral ligament attaching the femur to the tibia. You have the lateral collateral ligament attaching the femur to the fibula. Sometimes they're called the tibial collateral and fibular collateral ligaments. They resist stress that slides your femur laterally and medially on the tibia. The anterior and posterior cruciate ligaments control anterior and posterior translation of the femur and tibia. They also contribute to rotational stability. Now, between the femoral condyles and the tibial condyles are the menisci. The medial and lateral menisci deepen the tibial surfaces to help distribute load. Common knee injuries are numerous. Anterior cruciate ligament, or ACL rupture, is infamous, especially in pivoting sports. Meniscal tears are common with twisting on a planted foot or with degeneration over time. Medial collateral ligament sprains, patellar dislocation, patellar tendinopathy, and osteoarthritis are also frequent injuries of the knee. The so-called unhappy triad classically involves the ACL, MCL, and medial meniscus, though actual injury patterns vary. Patellofemoral pain syndrome reflects abnormal tracking or overload of the patella and is especially common in runners and active individuals. The knee is a lesson in how a joint can be both powerful and vulnerable at the same time. Getting down to the ankle area, we have the talocrural joint or ankle joint. It is a synovial hinge joint formed by the distal tibia and fibula, articulating with the trochlea of the talus, which is one of your tarsal bones. It permits dorsiflexion, pulling your toes up, and plantar flexion, pointing your toes. The shape of the talus contributes to stability because its trochlea is wider anteriorly, making the ankle more stable in dorsiflexion when the broader part is wedged into the mortise. Clinically significant soft tissues here include the deltoid ligament medially and the lateral collateral ligament complex laterally. These are composed of the anterior talofibular, calcaneofibular, and posterior talofibular ligaments. These are the injuries you see when you roll your ankle over. So when you're inverting your ankle in an inversion injury, you damage the lateral ligaments. When you evert your ankle out laterally, you damage the medial ligaments. And finally, that brings us to the joints of the foot. These are really similar to what we had in the hand. The joints between the tarsal bones, the intertarsal joints, are gliding joints. They allow some of the foot motion that you see when you can evert and invert your foot. And then we also have the tarsometatarsal joints and the metatarsophalangeal joints and the interphalangeal joints, which are all very similar to what we have in the wrist and hand. So I don't think we really need to go too deep into that. When we step back from the whole survey of synovial joints, a larger principle comes into focus. The human body doesn't simply contain a random assortment of hinges, pivots, and sockets. Instead, each joint represents a structural compromise tailored to its function. The atlanto-occipital and atlantoaxial joints provide the precise mobility needed to orient the head while protecting the spinal cord and vertebral arteries. The facet joints guide movement and resist excess motion in the spine. The sternoclavicular and acromioclavicular joints coordinate the shoulder girdle so the upper limb can move freely in space. The glenohumeral joint prioritizes mobility, while the hip prioritizes stability. The elbow and radioulnar joints position the hand efficiently. The wrist and hand sacrifice some strength for extraordinary dexterity. Clinically, the most important lesson is that joints are never just bones touching bones. A patient may present with pain in the joint, but the true source may be the capsule, a ligament, a meniscus, a labrum, a tendon, a bursa, or a degenerating cartilage. To fully understand injury patterns, we always have to ask what forces the joint normally experiences, which structures primarily resist those forces, and what trade-offs evolution accepted in designing that articulation. A highly mobile joint, like the shoulder, is more prone to dislocation. A heavily loaded joint, like the knee, is more dependent on soft tissue stabilizers. A region designed to transfer force, like the sacroiliac joint, may have very little movement, yet still be of enormous clinical significance. Okay, at this point, the pattern should be emerging for you. Joints are carefully designed interfaces whose material composition, shape, supporting tissues, and neuromuscular control all contribute to function. A synostosis provides fusion, where mobility would be harmful or unnecessary. Sutures protect the brain. Gomphoses anchor the teeth while preserving sensory feedback. Syndesmoses allow controlled flexibility where rotation or slight shifting is needed. Cartilaginous joints provide resilient unions that permit modest movement or support growth. And synovial joints create the highly mobile framework required for the extraordinary versatility of the human body. For students majoring in a healthcare profession, This material is more than a list of terms. It is a way of learning to think anatomically. When you see a motion, ask which joint class it allows it. When you learn a muscle, ask what lever it acts on and whether it favors speed or force. When you hear about an injury, ask which accessory structures are involved and how the injury might affect stability, range of motion, or proprioception. When you study pathology, ask how inflammation, degeneration, laxity, or fusion changes normal joint mechanics. Consider how these principles show up in real life. The body is not built as a series of isolated parts. Bones, joints, ligaments, tendons, cartilage, muscles, sensory receptors, and neural control systems form an integrated movement apparatus. Arthrology, the study of joints, gives us the architecture. Kinesiology gives us the action. Together, they explain how a person can nod, chew, grasp, walk, leap, write, reach, pivot, and recover balance after nearly tripping on a curb. They also explain why injury at a single joint can ripple outward, affecting posture, gait, load distribution, or even the person's own confidence of movement. So when you review joints, don't just memorize them as though they are static labels in a diagram. Think of them as living, mechanical, and biological systems. Ask why the skull needs immobile sutures, why the forearm needs a syndesmosis, why the spine uses fibrocartilaginous discs, why the shoulder uses a shallow socket, why bursae appear where friction is likely, and why the body so often prefers third-class levers, even though they do not maximize force. The answers reveal the priorities of human anatomy: protection where necessary, stability where essential, mobility where useful, and elegant compromise everywhere in between. That is the real lesson of joints. Human movement depends not only on one joint type, but on a hierarchy of articulations, each specialized for a role. Some unite bones permanently, some bind them flexibly, some cushion them, and some allow them to move through astonishing ranges. Together, they make the skeleton not just a framework, but an instrument of human action. One more time, thank you to Mykenzie for reaching out from Minnesota and requesting I cover joints. I hope this has helped you and everyone else get your beer better at A&P. Good luck, be well, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
Hey, it's Howie Mandel, and I am inviting you to witness history as me and my Howie Do It gaming team take on Gilly the King and Wallow 267's $1 million gaming in an epic Global Gaming League video game showdown. 4 rounds, multiple games, 1 winner, plus a halftime performance by multi-platinum artist Travie McCoy. Watch all the action and see who wins and advances to the championship match against Neo right now at globalgamingleague.com. That's globalgamingleague.com. Everybody games.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.